Okay, give me a thumbs up. Excellent, thank you. Right, let me share my slides. Can you see Alison, can you give me a thumbs up? Excellent, okay. So as Roger said, my name's Catherine. It's a real pleasure to be invited to speak this evening. I am an occupational health nurse, but I am also dual qualified in safety, and have worked in both areas. And I'm kind of equally passionate about both. I had the opportunity to do my NEBOSH training when in my first job in the steel industry, well over about 20 years ago now. We haven't got much sort of heavy manufacturing left in this country, but it was a really good starting point to learn everything occupational health and sort of safety related. These days I have my own company, which is Harmony Health and Wellbeing, and I focus more on occupational health, a little bit of safety, and moving forward this year getting more and more requests for the wellbeing agenda. Now I'm going to be talking a little bit about post-COVID syndrome, or post-COVID symptoms, aka long COVID, this evening. Please do put any questions in the chat box, and Alison will feed them my way later. I have to fully admit though, I, like everyone else, has learned everything COVID, both through personal lived experience and basically as we went along, as the rules changed again and again and again. And I'll be talking more about that shortly. So let's see if this works. Okay, so back then, you may remember, and Alison always used to love these slogans whenever we spoke. She'd always remind me what the latest sort of Bojo slogan was. And of course, very early on, it was all about staying at home, protecting the NHS and saving lives. And I think a lot of people have forgotten that, because it has been a long time now. But my personal journey with COVID, and to be honest, if I'm honest, a bit of long COVID or post-COVID symptoms started a bit earlier than for a lot of people. At Christmas time, I actually live in Finland, and at Christmas time, back then I was working in a hotel in December 2019 as a wilderness guide of all things, and I flew up before Christmas on a absolutely jam-packed plane, most of whom were Chinese tourists from Helsinki to Lapland. 90 minutes in the air, and there were two people about 2 rows behind me, one of which pretty much sneezed the whole way and the other one coughed the whole way. And even though it's kind of normal in the Chinese culture to wear a face covering, of course they had to take them off every time they sneezed or coughed, you know, so they could cough into a tissue and blow noses and things like that. And I just knew I was going to get something, and boy did I. I can honestly say I've never had a chest infection like it. And if you remember early on, those symptoms were very much around a dry cough. And indeed, most of the chest infections we see in the UK are either bacterial or viral, but if they're bacterial, they're pretty kind of wet coughs. And so I'd never experienced anything like this. And every time I tried to lie down, for example, I'd cough, and it was just absolutely draining for me. And it took quite a long time to recover. And then when Bojo made his big announcement of shutting the country down, I happened to be at about 30,000 feet flying into Gatwick. And I had 10 days of back-to-back health surveillance, you know, jam-packed days to fit in with a load of defense aircraft engineers. And I remember getting off the plane and making my way to baggage recall, and just like Roger was talking about earlier, everybody else's bags of course came apart from mine. So I'm standing there waiting, getting annoyed, and then I go and sit down, and you know when you kind of lay back and you look up and there's Bojo on the TV screen and the breaking news, lockdown announced, and of course there's that normal sense of panic. Oh no, what does it mean for me? What do I do? And then my phone went ping, and my partner, who's Finnish, said, oh, just to let you know, Finland are closing the borders, but we don't know when. So that was my introduction in a multi-country way to the realities of lockdown. So this was back then, but very sadly, this is where we are now. This is the COVID-19 dashboard from Johns Hopkins University, and they have a very interactive set of measures, both for the US and worldwide. And the figures in the top in red are the total cases, you know, and these are just the total known cases, those that have given a positive sort of test result. And that's quite a shockingly high number, but of course in reality is many, you know, times more than that. Over 5.5, you know, million deaths related to COVID or COVID complications, and of course all different countries measure COVID related death in a slightly different way, but it's just huge. And the images that will definitely stay with me for many years to come were those sort of overflowing funeral directors, and you know, and loved ones ultimately being stored in refrigerated containers in some countries, for example. So the toll has been absolutely huge from this infection. The good news, I suppose, is the green number. You know, I mean, how many noughts is that? 369. That's a billion, isn't it? So we're heading towards 10 billion vaccine doses administered worldwide. You know, and what this infection has showed us is the sheer speed at which countries can pull together and work hard and are willing to take risks when they need to protect the public health agenda. So you don't need to worry too much about the numbers here, but what I wanted to show you, this graph represents the 3 waves of COVID, and as you can see, the last one is incomplete. So the first sort of grey peak was about number of hospital admissions back in April 2020. So this was early on. And then the second peak, and of course that was Alpha, the old Alpha strain. Little did we know that Delta was going to come along and hit us incredibly quickly. The speed that it spread across the UK was, you know, in other countries was absolutely phenomenal. And that was just over a year ago. And as you can see, cases sort of got going again, but stayed fairly flat after the end of the restrictions in the UK. The peaks in blue were the number of critical care admissions, and by critical care they kind of mean a mix of intensive care, high dependency care, and you know, those guys that really needed very close support and were at risk of becoming very unwell very quickly. And as you can see, that the vaccination program sort of did take effect. If you remember, we didn't start vaccinating until just before the second peak. So by the time the country opened up, you can really see the benefits of the vaccines. Of course, what we know now, though, is that there were disadvantages to being so quick and early, in that we've needed to do the old Boost the Nation campaign to help reduce the impact of Omicron. And of course, again, as much as it's been about protecting the vulnerable and saving lives, the key drivers has been around protecting health service capacity at the end of the day. And that's the tricky balance, because now we have a huge issue with the backlog of operations, and that's going to have a huge impact on health and safety practitioners, you know, going forward, because we also have an aging population, and there's a huge number of people out there waiting for hips and knee replacements and other, you know, routine surgery that may impact on their workability and their ability to work safely. But sticking with COVID-19 for a moment, these slides, by the way, these graph slides and the next couple come from a presentation I attended given given by a gentleman called Dr. Paul Cullinan. And Paul is a respiratory consultant at the Lungs at Work team at the Brompton Hospital in London, and he's heavily involved in workplace respiratory disease. And the great thing about Paul is he's really down to earth, and he'll get through to the nitty gritty of what we really need to know. So I nicked some of the content from his slides, and I really liked the next bit that he covered with us, because what he was saying is sort of COVID-19 isn't really flu, and it's also not really an airways disease, because the virus itself had the potential to affect what we call receptors. So these are certain cells that the virus could bind with and then infect and then multiply. And this particular strain of coronaviruses had the ability to affect receptors in the alveoli, and the alveoli are the smallest air passages, you know, sort of right at the bottom of your lungs. So you've got your nose and your mouth and the throat, and then you've got your windpipe, and then it divides into your bronchi, and your bronchioles getting smaller and smaller and smaller, and your alveoli are where the oxygen gets absorbed through, and the carbon dioxide sort of, you know, passes through to be breathed out. And they could also affect the small bowel, but very much less so certain receptors in the throat and nose, which are more typical of influenza, which is a virus, but a very different virus. And indeed, the early symptoms were very different as well. So for COVID-19, we saw breathing difficulties, dry cough, diarrhea, what we call crackles on examination. So if you listen to someone's chest with a stethoscope, you know, right low down, you'll hear a crackle. It's a bit like sort of plastic, sort of bubble wrap if you kind of ripple it. And also, what became more pronounced as time went by was this loss of smell, possibly with taste as well. However, with influenza A, you know, it's more sore throat, sneezing. It's what we call an upper respiratory tract infection rather than a lower one. And also, what we learned about through the news was the incubation periods. The incubation period for COVID-19 was actually quite long. You know, if you remember, initially we were quarantining for 14 days, I think it was, before it then changed to 10. And indeed, as the strains have changed and you know, evolved as they do, and you may have heard on the news today that it's about to reduce again to 5 days with 2 negative lateral flow tests, including one on day 6. And on that point, actually, there is a, if you go to the gov.uk website and the coronavirus page, if you scroll down to the bottom, there's the latest news. And the article there, which I've just read, is really useful for looking actually what does this risk mean from your businesses and customers perspective, because, you know, by reducing it by a day, it does mean that some of the people, they may not score negative, they may score negative lateral flow tests, but some of them may still be contagious at that point in time. So it's worth having a read of that SAGE, you know, the committee that does all the technical and science crunching for the data there, particularly if you have staff or clients that are more vulnerable. Now, the interesting thing about this particular graph, which is looking at sort of COVID sort of versus flu, the solid grey graph, which had a peak at about 600 admissions, that was from what we call influenza or viral pneumonia back in 2019. So you may have heard about the pressure on beds and hospital beds in winter, but it has always been a problem every year. The number of people needing to be admitted to hospital due to breathing problems and adult respiratory distress problems. But what's interesting is if you look at sort of the 2020 sort of dotted line and the 2021 line, so far there's been you know, very sorry, we're now 22, aren't we? Sorry, the 2021 line, you can also see that actually there's been very low levels of viral influenza and associated pneumonia. And again, you will have heard in the news about sort of people gaining a sort of an immunity deficit almost through these long periods of working from home, avoiding contact with other people. You know, our immune systems are designed to be stimulated. You know, it's not about people not getting the infection at all. It's been about protecting those at greater risk of more serious disease and therefore hospitalization and death. That is what a lot of the restrictions have been around over time. And the next slide looks a bit complicated, but just bear with me. You'll see the graph on the left, and basically in the UK there were in 2020 over 31,000 patients discharged with COVID, having had COVID-19, and yet the number with pneumonia in the year before was over 68,000. And what these graphs look at is the complications or the problems that people had in the months following their discharge from hospital for either COVID-19 on the left and pneumonia on the right. And basically the point of showing you this is that the graphs are actually fairly similar outcomes wise. And if you look, I don't know if it's too small, but along the bottom, what they were counting was risk of or incident, I should say, of stroke, DVT, which is a blood clot in the leg, PE, which is a clot in the lungs, heart failure, a heart attack, problems with your kidneys, and development of type 2 diabetes. So as you can see, you know, pneumonia is a serious condition, but a lot of people were claiming that sort of pneumonia from COVID-19 was potentially worse than other pneumonias. But certainly from a post-hospital discharge complication perspective, the incidence is fairly similar. So going on to, I was about to say long COVID. I've been asked to call it post-COVID symptoms or post-COVID syndrome. There's been a couple of research studies that Paul shared with us. And so this is one from patients hospitalized in Hull. So it's a local one. And what they found is that in this survey, you know, residual symptoms that were common were breathlessness, anxiety, fatigue, and low mood. They were more common in women, and the longer the follow-up, you saw how they tailed off. And what was interesting is that even though a lot of people complain of breathlessness and other breathing problems like cough, all their chest X-rays cleared. Okay, so if they may or may not have been admitted due to pneumonia, because don't forget COVID-19 could cause, you know, affect different systems of the body, not just the lungs, but for those that needed chest X-rays, they were all normal. And the key thing to bear in mind with post-COVID symptoms is that the symptoms people seem to experience is unrelated to the severity of their initial illness. And this has been the tricky thing with vaccination and the like, and you know, in trying to prevent not just severe disease, but also post-COVID symptoms. And this particular research was from Norway, and it did a follow-up sort of 6 months after a positive PCR test of 451 patients that were not hospitalized, and they managed to follow up 48%. But what was interesting that at about 6 months, 80% had no respiratory or breathing symptoms like the dry cough, the dyspnea, or the sort of shortness of breath, or a sense of wheeze. And there's a big long list here of different symptoms that people were complaining of. And I think breathing is an interesting one. Aches and pains, you know, sort of changes in cognitive function, and loss or changes in sense of taste and smell are the ones that I'm seeing that have had the most impact, certainly in patients that were not hospitalized. But what you need to bear in mind, though, is that when you actually get talking to people, and I've had a few people referred to my clinics, either because they're at work and they're struggling with symptoms, or they're struggling to return to work, and HR or managers are asking for advice, is that to gain help was incredibly tricky for a lot of people. A lot of people with a positive COVID-19 test, particularly those that are maybe a bit more stoic, they put off asking for help and admitting to the extent of their breathing problems, not just with loved ones, but also with maybe family doctors and maybe A&E, etc. And even if they did get through to someone, often they weren't ill enough to be asked to attend the A&E, or they were low down on the queue for ambulance assessment. And even when ambulance did come, if their SATs were, or oxygen saturation, sorry, their SATs level was quite good in the grand scheme of things, and they were otherwise fit and well, then they were not taken to hospital, partly due to the sheer pressure on beds. And then in some parts of the country, there were schemes where people with symptoms could phone up and be assessed. In one area, there was 2 nurses, which was quite worrying. And I remember one lady I spoke to, she said that this nurse, whose role was to assess COVID patients for severity and identify who needed to be admitted to hospital, etc., and have further tests, she actually had a letter from this nurse. And when she went to A&E, they said, it's not our problem, you need to go up to the COVID-19 assessment unit. And then when she got up there with this letter, they said, that's not us, you need to go back down to A&E. And this lady's struggling to breathe. You know, she's scared. And that has been the reality for a lot of people that have had new symptoms of a severity that they haven't experienced before. And the advantage that we do have with the NHS, particularly if you've ever had to use it, and the ambulance service, is knowing that it's there and knowing that help will come in a non-judgmental way, usually pretty quick. Albeit, of course, there's delays at the moment, but they would always come and assess you, and that wasn't always happening. And so the fear element, you know, adding on to people's levels of distress has been huge. And that's before we look at people that have successfully been admitted to hospital, because their experience and what they've described to me is, well, I got admitted to hospital for 3 nights because I was struggling to breathe, said one guy who was 29, but he was a big guy, 29, and his oxygen saturation levels dropped, and he needed just an oxygen mask for a couple of days. And there was also another lady that I spoke to who was coughing so hard she was struggling to eat and drink enough. So was getting dehydrated, and she was admitted not for oxygen support, but for a drip, you know, to keep her hydrated. And she was in for about 48 hours before being discharged. But what they both said was the level or the sense of fear within the ward environment was just huge, you know, absolutely huge. And of course, the staff were scared of catching the infection and taking it home to loved ones or whatever. So patient care wasn't necessarily at its highest, And that's also understandable when you think about the varying levels of PPE availability early on. Now, as safety practitioners, we understand about FFP2s and FFP3s and surgical masks with gaping holes at the side, etc. And the realities of supply, during the pandemic. So what they were describing to me is that there was so much coughing that, in the ward, for example, that people couldn't sleep at night, which then put their own anxiety up, which then affected their breathing even more. And then the only time they saw a nurse was, at the medication rounds, or for, eating or drinking, or if someone, rang a buzzer, and they found that very, very scary too. Even though, of course, and this isn't me knocking, healthcare workers at all, but that was the reality that people were describing. And of course, after discharge, and when they're back home, and of course they will have been discharged early as well, they could have still quite severe symptoms, and otherwise fit and well people may have been struggling to help themselves for a while and really get back on their feet. And no one wants to be admitted to hospital at any time, and certainly not admitted to intensive care. And one lady I spoke to recently said that she was admitted for breathing problems. She was a lady in her 30s. She was admitted last April with breathing problems, and then the steroids they gave her to treat her induced diabetes. So she ended up in intensive care because she had steroid-induced diabetes. Now, she needed the steroids to treat the breathing problems, but they caused another problem, and she was a pretty unwell lady. And it's quite common, if you've been a patient in intensive care, particularly with all the noise, the beeping, the very severely ill people that you're surrounded by, to have post-traumatic symptoms afterwards. It is a very difficult place to be. And she managed to return to work and then crashed a few months later, and that's how she ended up in my clinic. So those are just things to bear in mind. It's very easy to talk about symptoms like, oh, still being breathless or this or that, but actually we need to consider the person from the wider perspective, and that's what I'm going to go on and talk about in a minute. So to summarize this part then, what Paul Cullinan, this respiratory consultant, was saying, that COVID-19 is not an airways disease as such. It's likely to behave like other pneumonias, and some people will have, as we saw in the graphs, non-breathing related complications like heart attack, stroke, diabetes, whatever afterwards. But in reality, the majority of people admitted to hospital with pneumonia will recover completely, and also fairly quickly. And the issue is that a lot of people with symptoms assume that symptoms means there's disease. There's an underlying disease process, and that's not the case. And it's one of the reasons why this is titled post-COVID syndrome. So a syndrome is a collection of symptoms without any obviously sort of diagnosable cause. So chest X-rays may be normal, CT scans may be normal, and what he's advised, and it's certainly what I've seen as well, is that many causes of breathlessness won't be due to a disease process, but what we call dysfunctional breathing. And there are risks associated with X-rays. We're exposing people to radiation, both staff and the patient. So a lot of patients want investigations. Why am I got this post-COVID symptom? And doctors will often do blood tests initially, but they won't necessarily do anything further. And this was a quote that came from, believe it or not, a firefighter in his 40s that had long COVID, and then that had COVID and then continuing symptoms afterwards, and he was struggling to get back on the run. and he got referred to Paul's team for any advice. And basically all his investigations were normal, apart from one vitamin deficiency, which was corrected. And he, like many other people, have said this, you know, I write this to my fellow COVID-19 long haulers, is another word for them, or description, whose tissues have healed. So the infection, he's had the infection, you know, his tissues have healed, but, you know, he's still got some symptoms. I have recovered. And I did this by listening to people that have recovered, not the people that are still unwell, and by understanding that our unconscious normal thoughts and feelings influence the symptoms we experience. So I included that because it's part of the learning journey for those with post-COVID symptoms. You know, it is a journey, and you have to find your own way through it. So I just wanted to share a couple of quick case studies with you. The first one is a colleague of mine in the States. She's a nurse manager, and she managed to do really well because she worked all the way through and eventually contracted COVID in December 2020. And her role had been both patient contact, but going around face fit testing all the staff when they finally managed to get their hands on some FFP2s. And this lady is one of those super sharp, amazing analytical brain. I mean, she's the total opposite to me. You know, I have to write everything down. You know, my brain is clumsy. I lose my track partway through a conversation, blah blah blah, unless I know the topic really well. And she was super sharp. And then she got COVID. And watching her over the following months, and that was really, really interesting, because her brain refused to work, and her biggest problem was the cough. And the cough continued for many months, and she actually coughed so hard over time that her disc prolapsed in her neck. She had to have spinal surgery, and you know, once she'd had the spinal surgery, she then had to rehab from that as well. But having the surgery was really risky because of her lungs and the like. Now, 14 months on, she's made a full recovery and is doing well. But if you'd seen her 6 or 9 months ago, you would not have believed she was the same person. But a lot of her recovery was down to sheer stubbornness and, you know, doing her own, getting advice and then doing her own rehab, you know, slowly building up the exercise levels, pacing her activities, you know, really focusing on self-care, which wasn't something that prior to COVID, that was something that she was particularly so good at. Katie was this lady who had the steroid-induced diabetes, and she had the positive COVID test in April last year, and it took her a while to get admitted to hospital, even though she had quite severe breathing problems. She was kind of borderline bad enough, which sounds absolutely awful, but that has been the reality and the pressure on services and beds. She was in hospital and then went to ICU. She managed to come out and return to work just 6 weeks later. She had an office-based job and was working from home. And then she had what was called an acute stress reaction in September and crashed, and mentally and physically couldn't cope with work anymore. And talking to her, you know, she really had quite strong anxiety symptoms that were a result of the challenges she had pre-hospital in getting the support she needed and her time in hospital. And what she didn't realize, and what many people don't realize, is that we're having to grieve. We've all experienced a huge amount of loss within the pandemic, and we're having to grieve those losses. And of course, in the West, we're not taught how to grieve. And grieving is the inward sort of expression of, the inward experience of kind of loss and challenges. And it's the mourning, it's the tears, the other things that we do, be it singing, dancing, art, whatever it is. The mourning aspect is the outward expression, and so a lot of people are grieving and mourning right now, but don't realize it, and don't realize that actually it's an active process that you kind of need to do, because she'd had to face her own mortality, and at 32, that is huge. She was the one who thought she was protecting everyone else, and she was, until a family member gave it to her. But then all of a sudden, she couldn't do that. She couldn't meet with her friends. She couldn't meet with her family. And her background is Indian, so they're very close-knit family. This is me as a wilderness guide. As I said, the biggest problem for me was cough for a number of months, and every time I laid down, I started coughing. So a humidifier was a key piece of kit by my bed every night. And full recovery took about 12 months. But as a wilderness guide, we spend a lot of time outside in very cold temperatures, breathing cold, dry air, and a cough and that does not work together. The biggest problem for me was breathlessness, and I'd be absolutely fine. I could go for an hour, 2-hour walk, and then the slightest slope or the stairs up to the front of our house, and I'd be huffing and puffing and wheezing, and I was like, this is ridiculous. I'm not that unfit. And eventually, over time, I had to keep going with the exercise. Of course, things eased off. And then I finally had a man in my clinic with breathing symptoms, and interestingly, he was COVID negative. So he had actually had a different form of pneumonia, and again, it took him a long time to get the X-rays and to be properly diagnosed with pneumonia. And he was admitted overnight and then discharged. But again, he was wondering, why can't I've just had a bad chest infection, why can't I just get on with life? But pneumonia is a chest infection, is a severe chest infection. And again, he needed advice around sort of fatigue management, sleeping better, and one of his biggest problems was his mood had dropped because he wasn't working, wasn't able to socialize. But interestingly, only 4 months later, he had recovered. So just briefly, this is my approach at the moment. Some of you may be aware of the sort of 8 dimensions of wellness model or others, but basically each of these different factors, social, spiritual, occupational, emotional, are all determinants of our health. And certainly within the occupational health clinic, when someone is referred, we don't just look at the symptoms. We've got to look at the impact of those different symptoms on both their life outside of work, but also their ability to work and any risks that may come with those. So what I've done is, and I appreciate this is not necessarily the easiest to read, but bearing in mind that post-COVID syndrome is a collection of symptoms rather than a disease, then the areas that I'm focusing on are in a consultation is in yellow, and the ones that you maybe need to be aware of as safety professionals or supervisors or managers, or just from your own perspective and family and friends perspective, feel free to share this information, are in red. So when people have experienced loss, it can affect mood. The fear around COVID-19 and recovery can affect anxiety levels, and both of those we know pose an increased risk of accidents. If you've got brain fog, there's going to be frustration, like my nurse manager colleague in the States, frustration at reduced concentration, memory and focus, forgetting things, having to write things down, learning to work differently. And a lot of it is about regaining confidence and trust in our own minds and bodies, and our ability to make decisions. So for those of you that work in safety critical industries, and I have customers in rail engineering and aviation engineering, for example, I really have to consider human factors and flag them because they're very difficult to measure. You really have to go on the individual and encourage the supervisor for supervision to actually supervise, you know, rather than be too distance. There's the, you know, sort of being able to keep up with colleagues, particularly in physical jobs, but also this sort of perceived difficulties with wearing hygiene and PPE. The sort of the need for personal space, and a lot of people sort of close down a bit when people come near, or they're holding their breaths, and actually they need to expand, you know, and learn to breathe properly again. We'll talk more about that in a minute, you know. And when people have had a near-death experience, or they've had to face their own mortality, or a family member has had to at a much younger age than ever expected, or out of the blue, then it can have a real impact on purpose and meaning in life. And you know, we not only grieve loss, but we also have to work through sort of helplessness. A lot of us felt very, very helpless during COVID, and any sense of guilt or shame that's there. And that's where, like, employee assistance providers are so important, you know, and you encourage people to have a chat with a counsellor or a therapist there. Because again, people's attitudes to risk can change. They can become more risk averse or less risk averse. And indeed, when you get mood levels, you also changes, you may also see the can't be bothered sort of factors. And of course, one of the biggest well-being challenges right now for people is financial. You know, there are a lot of people and who are struggling. They're on Maslow's pyramid, they're on the bottom, they're on survival, you know, particularly struggled when children were at home and homeschooling and everything as well. You know, really, really crazy times. So there's nothing new here, but it's just an opportunity to flag it in a slightly different way of, you know, sort of considerations when it comes to behavior and risk-taking behaviors, and also sort of supervision of behaviors, you know, and what would normally be accepted in a workplace may well be shifting, you know, over time. So you need to bear that in mind. And also just de-skilling and loss of knowledge, particularly if people have been working from home. You know, you can't expect them to, you know, 1 year later to be fully knowledgeable about everything happening in the workplace. And indeed, you may need to do inductions for staff that started working from home and started their role, you know, during COVID, during lockdown. I've seen a lot of those struggling with their mental well-being and struggling to fit in with the team. So the last few slides are just resources that and links that you can look at in your own time. So I'm just going to whiz through these. Physiotherapy for what's called BPD, or breathing pattern disorders. This is a really good free leaflet, and basically a lot of the time at the moment I am teaching people how to breathe again, because most people are sort of breathing in the top couple of inches of their chest, and they need to learn to breathe down, forward, sideways and backwards, and really fill their lungs again. So I encourage you right this moment to see if you can fill your lungs. Pop your hands on the side, on your lower ribs, and just breathe to the fingers at the front, breathe to the palms at the back, breathe, you know, breathe to the thumbs, and really fill your lungs forward, sideways, backwards. And when I challenge people to do this, you know, within 2 breaths, they're like, oh my gosh, I've just unlocked my breathing. Or, oh wow, I haven't breathed like that for a long time. And you see their color improve, everything. So the more you can breathe properly, the more your body will come back into balance. And a lot of symptoms that people complain of that are on this slide, like breathlessness, tingling, chest pain, anxiety symptoms, will often start to ease because the breath is so important. Interestingly, there was a HSE document from March 21 looking at the evidence base and return to work. Main issues affecting work and return to work were fatigue, concentration and memory loss, and changes in taste and smell. And and again, it's nothing new on the return to work interventions, the reduced hours, flexi time, phased returns, working from home, moving to a role temporarily with reduced physical demands, etc., etc. This is one of the best booklets to download. It's actually the Scottish health improvement body, and it's a really good booklet that talks you through long COVID and gives advice both to health professionals and to individuals. This website is the NHS website, and you can download various PDFs, but they're all by section. So this is worth having a look at. And again, these are the commonest sort of post-COVID effects that they give advice on within these sort of websites. And interestingly, it talks about recovery, so it's about convalescence, which we're not very good at doing these days. It used to be normal to sort of convalesce, to recover over time and pace yourself and build up activities. So if you look at this, the middle section under your well-being, it's talking about eating well, sleeping well, getting moving again. And a lot of people are fearful to do that, but we need to encourage them to find their own path back to good health. And if you know anybody like our poor 12-year-old who had real problems with taste and smell when she had COVID at Christmas, there is a good charity called fifthsense.org.uk, and they have really good information about smell and taste and how they're linked, and also how you can sort of start to retrain, because your smell is linked to your ability to taste, and also certain things like I think I read it was like onion and garlic can trigger these changes in the perception of food and drink. So for example, our daughter stopped being able to smell the dog. Now, to me, the dog doesn't smell, luckily, but to her, he had a smell, and then when she had COVID, she could no longer smell him. And about 3 or 4 weeks later, that came back, and she was so happy. Unfortunately, a lot of foods she describes as rotten, and also strong metallic tastes is another one. And as a family, we regularly sit down around the table, and she's lost sort of enjoyment in food, so it has huge knock-on effects when people have problems with senses. Okay, and that is it. So over to Alison for the questions.
Great presentation, thank you, Catherine. And we're getting some nice comments coming through along with questions. So Steve Butler asks, will nasal breathing help with breathing and breathing pattern disorders? If you need more information, do feel free to ask Steve to come off mute and talk to you.
If you look at the information sheet on the breathing pattern disorder website link that I put there, they actually talk about breathing in through the nose and breathing out through the nose if you can. But as a yoga teacher, we often talk about breathing in through the nose and out through the mouth. And one of the reasons for doing that is that it's easier to breathe out through the mouth, but also it's easier to make the out breath sort of longer. So there's no real right or wrong. I think it's about what works for you. And the key thing is you're learning to expand your lungs and really fill them sort of forward, sideways, backwards, and up. And you'll see a change in people's facial color very quickly and their level of sparkle when they start breathing more fully. It really is important.
That's great. We haven't actually got another question at the moment, so I'm wondering whether we should have a team breathe.
Oh, okay. Well, first of all, Alison will like this. We need to have a bit of a wiggle. So come on, get your bodies wiggling a bit, because of course, all this top bit that's been sitting so still, listening so diligently, has got a bit stuck. Yeah.
This is fabulous wiggling. I'm loving this. I wish I'd got my video camera at this precise.
Oh dear.
I'm not saying anything, but it's not Wiggle Wednesday. Only Alison will appreciate that.
A Wiggle Wednesday. So if you just want to roll your shoulders back and really raise them to your ears, backwards, So your shoulder blades sort of move together, and down. Because when we're stressed, our shoulders kind of go up, 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 and then we're kind of like no necks. Okay, so really sort of have a sense of, if it's a bit tight and achy, just slowly and gently kind of what is needed to get a bit of balance there. Okay, and sort of wiggle to the left and sort of wiggle to the right and kind of look over a shoulder. Oh dear, better not look too long. That's a bit messy that way. Yeah. Look over the other shoulder.
I'm not taking my eye off this screen.
And also you can stretch up and stretch down and backwards and whatever feels nice. Now you see, when unfortunately most of you haven't got your cameras on, but if we'd have compared sort of facial colors, a lot of you would have looked a bit pale and kind of and just that few seconds of stretching and moving and having a bit of a giggle, you know, people's faces, like Les and Kate's got a nice smile on her face, Alison has lit up, you know, so this is typical of what we see. You know, so if you want to improve your productivity and wake yourself up, have a good wiggle and breathe. It's free. So with this breathing thing, what you have to do, it's a yoga technique, the one I teach, called the complete breath. Okay, and so you need to put your hands like this. Come on then, let's see your hands. Yeah, and what you do is you put them in at your sides, just above the waist on the lower ribs. So the fingers are at the front, the palms are at the side, and the thumbs are at the back. So on, there goes Alison's cat every time. Oh, Raffles. Oh,
he has to take part.
Yeah. So on one breath, breathing in through the nose, breathe to the fingers at the front, and then the thumbs at the back, and then the palms at the side, and then breathe out through the mouth. Okay, did you get that? So we're going to do it again, this time breathing in through the nose to the fingers at the front, the palms at the side, the thumbs at the back, and then upwards, and then so your breasts come up and then a bit more, so your collarbones come up, and then squeeze in a little bit more, forward, backwards, sideways, and then breathe out with a sigh. Oh wow, look at you lot now, you're all sparkly and awake. Yeah, so how did that feel? Give us a quick bit of feedback. Les, how did it feel? You're on mute, mate. Oh, we got a thumbs up from Keith. There is life.
Slightly dizzy.
Slightly dizzy, yeah. Yeah. So you've had a bit of an oxygen boost, a bit of a whoosh.
I reckon.
Yeah. Yeah. So a lot of people worry about a bit of dizziness, but it's just getting used to it, you know, because we have so many muscles in our chest wall and also the diaphragm at the bottom. And if you're someone who worries a lot or is finding themselves more anxious, then there's two things that you can do. One is what we call the anchoring heart technique, and you put one or both hands sort of over your heart or your chest space, and you breathe to your hands. And this is great for someone who's having a bit of a wobble or a panic, and it's kind of self-nurturing, but it's also what we call grounding. Yeah, so it's bringing the person out of a scattered, wobbly state, an anxious state, and back into the here and now. And this will take someone usually out of a panic attack within seconds. So teach it to your kids, teach it to, you know, friends or family that are having a bit of a wobble, and also just use it for yourself, you know, when you're maybe settling into bed, just to take a few deeper breaths. And it can be two hands or one hand on your heart, one hand on your belly, but it's just a kind of a deep breathing deeper and then a letting go. And this breathing out through the mouth is a form of expression. You know, I was saying about grieving and mourning. So I can't remember who asked the question, but one of the reasons for breathing out through the mouth, particularly with sound or sigh, is that it's a letting go, and you're letting go of tension and energy and that's held, and hurt and loss that's held within the body. Okay, so that might sound a bit wacky to some people, but our emotional and our psychological well-being is not just about what's going on in our heads. You know, so if you're prone to anxiety symptoms, then it's all about the breath. And the reason for doing sort of this one and this one is that when you breathe to the fingers at the front, the palms at the side, and the thumbs at the back, you're also flattening the diaphragm, which is a muscle at the bottom of your lungs. And what that does is kind of give the organs underneath, which are the top of your kidneys and your sort of bowel and that, a little massage. And on top of your kidneys are the adrenal glands. And yes, they produce adrenaline. So when you breathe deeper, it goes, hey, chill, dude. You don't need to be producing all that adrenaline. Hey, will you calm down? And there is research to show that what we call diaphragmatic breathing, which is really breathing deeply downwards and forwards and sideways and backwards, etc., it reduces your blood pressure. It reduces the level of stress hormones in your circulating in your body. Okay, it reduces the pins and needles and tingling that comes with over breathing. Okay, so this breathing thing is really key for all of us to understand and get our heads around. So if the only thing you commit to doing after today's session is looking at that website about breathing, or just becoming aware of your breathing more of the time, then that would be fantastic. And the more that you can teach your colleagues and your friends, you know, just notice and say to them, oh, you look like you're holding your breath, you know, breathe. Hey, I learned this really good technique the other day. Humor me. She said to do this, just press gently and firmly on your chest, and then you just breathe. That's all. And they can do it. You know, kids can do it. They love it. And they'll teach each other, you know, and it really is helpful for people regaining control. Okay, so that was a hint and a tip. And actually, that's what I spend most of my time doing in an occupational health clinic. It's teaching people how to breathe. It's great. I love it, you know, because people really feel they have a tool in their toolbox to use. And actually, I taught this anchoring heart technique on Monday to a lady who really didn't want to talk to me. She didn't want to talk about her past or loads of trauma and stuff like that. And I said, look, let me teach you this tool, because it's linked to the neuroscience and the stress hormones and everything that's happening. And at the end of the consultation, she was excited. I've never had that in one of my consultations. She said, I'm so excited. Oh my God, it works. Oh, I've got something that I can trust. And oh, wow. Oh, this is great. I'm going to teach the kids. So please share it. And I'll also share an instruction card and a bit of information about it as well. But any questions, feel free to, or anything that's not clear on the slides, feel free to pass to one of the committee, and I'm more than happy to follow up with anybody that needs any advice or support.
Lovely. That feels a fantastically positive note to finish on. So Roger, may I hand back to you?
Yeah, lovely. Thanks very much, Alison. So I've made just a few notes here, Catherine. So we love case studies. We just adore case studies. Thank you very much for those. And I was particularly interested in the age ranges of those in the case study, because certainly from the earlier days, we tend to think of it as you know, those affecting the elderly, but as we can see from that the younger age range is equally affected. Also the post-COVID syndrome slide with the 8 areas in Occ Health, and now the 2 aspects that you highlighted around, certainly from a manager's point of view and behaviours, was absolutely superb. And thanks very much for the links. And I've got a big post-it on here. I think we're going to have breathing sessions at every IOSH Midshires meeting now. So what I'm saying, committee, on a Monday, right? Don't forget, you've got it. Just get practicing. But absolutely superb, Catherine. Thank you so much. Yeah, I think everybody on this call has thoroughly enjoyed it. So a big round of applause. I think the usual Midshires. Thank you.
Oh, thank you, everybody. It's been a pleasure to come. Thank you.
I've never seen so many smiling faces. It's been absolutely superb. Thank you so much.
Yeah, you can have fun at a committee meeting. I love it.
Absolutely. And in fact, going back to my earlier point about the committee, we do, and we've all got smiling faces. So please, if you want to join us, get in contact. So without, leaves me nothing else to say other, obviously a big thank you to Catherine, but thank you for all of you that have attended this evening. It's nice to see so many of you, and please stay safe, keep well, and we'll see you next month. Thank you so much. Thank you.
Well done, Catherine.